And now we have our keynote speaker, Dr. Nirav Pandya, a pediatric orthopedic surgeon and sports medicine specialist within the UCSF Department of Orthopedic Surgery. He is the vice chair of pediatric operations and the section chief of the Division of Pediatric Orthopedics. His areas of interest include sports medicine, arthroscopy, and pediatric trauma, as well as general pediatric orthopedics. Dr. Pandya received his undergraduate degree from the University of Chicago, and then he got his medical degree from the University of Chicago Pritzker School of Medicine. Then he went on to complete his orthopedic surgery residency at the Hospital of the University of Pennsylvania in Philadelphia, and then a fellowship at Rady's Children's in San Diego. Dr. Pandya has over 60 peer-reviewed publications and multiple book chapters. He speaks regularly at national and international conferences, and also co-hosts 6 to 8 weeks Perspectives on Sports Medicine, which is a podcast. You can also hear him on 95.7 The Game. He's also known as DJ Nirav. He somehow must have cloned himself, so I don't know which version we're getting because he does a lot of things, mainly to support his Warriors jersey habit. Dr. Pandya.
Yeah, I have a jersey problem. I have to talk, my wife's not very happy that I buy Warriors jerseys every couple days. So that's a whole other talk. So once again, thanks everyone for coming today. Probably everyone's really hungry, so we'll try to get through this and get you guys to lunch. But really what I want to talk about today is kind of more globally, not necessarily the specifics of using motion lab technology, but really looking at why it's important to utilize things such as motion analysis to return individuals to sports, particularly the pediatric and adolescent population. Because one of the things that you'll see as we kind of go through the talk is that unlike the adult population, pediatric patients have a much higher rate of failure. They have a much higher rate of stakes in terms of going back to sports. So how do we optimize their ability to go back to sports, reduce that risk of injury, and also prevent that injury from occurring at the same time? So what has typically been a domain of professional athletes and collegiate athletes and many athletes who are weekend warriors, I think if we utilize this technology in our youth athletes, we can make differences in terms of their performance and prevent their repeat injury risk. So really the objectives of this talk, number one, I think it's important whenever you talk about motion analysis technology to really talk about the epidemiology of youth sports, because you understand the importance of why we need to incorporate these things into our kind of care delivery. Because of the way kids are playing sports. And then it's also important to understand the high injury rate, the high rate of repeat injury, because that's where motion analysis can really make the biggest dent. Beyond surgical techniques, beyond protocols, it's really about how do we change the mechanics of how individuals are playing sports after they undergo interventions. We'll talk about some basic strategies for injury prevention that are rooted in motion analysis, and then really kind of hone in at the end on the role for motion lab technology and how it can be utilized at a center like this, how it can be utilized in your backyard, and how it can be utilized to help decrease some of the disparities we see in terms of outcomes for kids who are playing youth sports. So the first thing you have to understand is the culture of how kids are playing. If you look at how kids have been playing sports over the past 10 to 15 years, it's really become professionalized. Kids aren't playing multiple sports. They're not playing for their school team. They're not playing for their rec team. What they're doing is that they're playing sport to try to be professionals, even though a very small percentage of them, less than 0.1%, are actually going to make it to the next level. And you see all this media attention about how youth sports have become this professional endeavor. But what doesn't get talked about a lot is just the great degree of injury risk that occurs with this kind of model of playing sports. And there's a great website called Stop Sports Injuries. If you look for just basic information about sports injuries, it's really, really good. It has a lot of patient education material. One of the statistics they've had on there is that 50% of all youth athletes will suffer at least one significant injury a year. And that's an injury that makes you go to the emergency room, that makes you go to a subspecialist. It's a very high rate of injury. So a whole other talk could be how do we prevent these injuries from occurring in the first place. But I think it more than anything else really emphasizes how kids are basically going back to an environment which is set up for them to get injured. And what are the things we can control? It's hard to make a dent in terms of the way kids are playing sports. It's hard to make a dent in terms of how kids are specializing at a very kind of grassroots level. But if we change the way kids are playing when they're coming back off their injury and we're looking at their mechanics, then perhaps we can actually decrease that injury risk, and maybe this will be 25%, or maybe this will be 20%, which is a huge difference when you see the sheer number of kids who are getting injured. So a lot of the problem is single sport specialization. It's intensive year-round training in a single sport at the exclusion of other sports, okay? And if you look globally at kids' mechanics, right? So you look at kids who 30 years ago were playing multiple sports, and you look at them now who are doing single sports. The kids who are playing single sports maybe quote unquote more skilled. They can throw a baseball faster at a younger age. They can run faster. They can jump higher. But if you actually look at their actual mechanics, what's their core strength? What's their balance? How do they look when they're doing things? It's actually dropped, okay? Because when you're playing multiple sports, your mechanics are actually better. A lot of the stuff for injury prevention and ACL prevention programs, it's things that naturally would occur if you're doing multiple activities. Because kids aren't doing that anymore, they may be more skilled, but they're not necessarily developing those mechanical advantages that we saw from doing multiple things. So because of that, that's where things like motion analysis are really important. So we can decrease that injury risk that wasn't there before because kids naturally were developing these mechanical advantages, getting good biomechanics, because they were having to do it in multiple different areas. They were swimming, they were playing tennis, they were playing basketball. That naturally forced you to develop good mechanics to prevent injury risk. That doesn't exist anymore. So the way we can immediately deal with that is using things like motion technology. And then if you have young kids who are trying to get into youth sport, just encourage them to go and play in the backyard, right? It's okay to like go to the park and throw a football around. It's okay to play pickup basketball without any AAU tournament that weekend. Just little things like that will encourage kids to kind of use their bodies in different ways, and then maybe they won't get injured when they're much older. So if we really kind of quantify the problem of why things like motion analysis are really important, it's you have younger athletes who are specializing in sports at a younger age and positions and kind of basically not even just playing baseball, but they're like, I'm going to be a pitcher at age 8. And as a result, this really young group of patients, those who are under age 14, this number continues to increase. So if you look at 10 years ago, this number was like 1.5 million. Then it was 2.5 million. Now it's 3.5 million, and it's predicted to be 5 million under the age of 14 over the next decade. That's a lot of kids who are just in middle school or coming in with severe injuries. And you take this age group of kids, they've got immature bones, they have poor mechanics because they're going through puberty, they're not resting, all these things lead to these injuries that are basically then filling up our clinics, okay? And at the same time, you have more injuries and there's increased pressure return to play quicker, right? So these kids are coming in, they have these severe injuries and they want to play week 1, week 2, week 3, and they say, oh, I don't have pain, I don't have all these other things. So what can we determine whether they're ready is looking at their mechanics, looking at how they're moving, seeing if they're actually ready. Because if you ask a parent if their kid's ready to play, what's the parent going to say? The kid's limping, can you play this weekend, right? Okay. Can you give them a cortisone shot so they can get rid of their pain? So all these things that we need to help become more quantifiable with things like motion analysis will help. And I think the professional levels are really starting to understand how the impact of poor mechanics and overuse and sports culture are impacting professional athletes that are out there. This is an article that Baxter Holmes did, who basically, was a reporter for the Warriors, 5-6 years ago, and then come over to ESPN. Many of you have read some of his articles. But he had seen, talking to a lot of professional basketball players, just kind of the wear and tear on their bodies. And a lot of them said they look back at kind of youth sports and play AAU year-round, and they were coming in with so much more mileage on their bodies at younger ages and getting meniscus tears and ACL injuries at age 21, 22, 23. And what he also talked about was some of the biomechanics of these kids when they came into the league, is they'd been doing so much skill development. If you looked at their biomechanical profile in terms of how they were jumping, how they were running, there was so much more discrepancy in terms of how they should have been doing it compared to people 15, 20 years ago that was leading to these injuries. So not only were they playing too much sports, their mechanics were all off. So I think that once again emphasizes how not even at the professional level, they're starting to understand that, but if we can do that at our level, we can make a big difference. So if you look at a professional athlete, many of you are Warriors fans, you talk about Klay Thompson, 941 days away. That's a long time, right? And everyone's like, when's he gonna come back? And they wanted his mechanics optimized, they wanted all his strength, his conditioning, everything else, and it cost millions of dollars for the Warriors. Then you come into our clinics, okay, and you get this 10-year-old who comes in, and there's really no consequence to him not playing, right? But they want to clear that athlete at 6 months post-ACL. They want that cortisone shot. They want all these things that they want to basically get their athlete back on the field, but they're not mechanically ready, right? They may feel good, right? They feel like their ACL's healed, even though we tell them the ACL takes 9 to 12 months to heal. But then you get them doing things like running, cutting, pivoting, and then they fall over, they don't have good form. So these are the areas where we can make an impact in terms of helping our athletes get back safely, as opposed to just getting them back because they're feeling good, okay? So the reason why I say motion analysis is really important in this technology is because there's so many different pressures. You've got the parents and coaches on the sideline yelling through cones. It's just what I found on the internet, but I don't think that's actually happening. You've got all these pubertal changes, right? So what happens during puberty? Neuromuscular control goes down. That's why middle school kids are very uncoordinated, right? Everything's kind of out of whack, hormonal changes, et cetera. Then you've got the business of youth sports. You have all this money thrown in there as well too, and then you're seeing all these injuries, right? So you have all these multiple factors that are playing a role. But what we can do is by using motion analysis and technology that looks at movement, it's very subjective. It shows parents, it shows athletes, it shows coaches that, hey, there's some deficits over here. Let's work on correcting those, correcting them in the sense of, okay, you're healed from your injury and we need to correct them, or you're still injured. This is how it's manifesting. This is the reason why you shouldn't go back to playing. So I think we're really good when we see athletes who come in who are injured in dealing with kind of the first three phases of this: the protection, the load introduction, strength accumulation. We've gotten a little bit better in terms of integrating people back into training, okay? But where we really struggle is this part right over here. It's that you're healed from your injury, you've completed your physical therapy, you're doing well, but then how do you return to performance, right? Not return to play, but return to performance. How do you get back to that level that you need to be effective, right? So that's where that motion analysis comes in. You're effective because your mechanics are optimized. You're effective because you're not having pain. You're effective because you truly are healed from your injury. And that healing doesn't occur when your pain's gone or you've got full mobility, you've got full strength, or your graph feels good. It's when everything that goes into making you an athlete, which is dynamic, is corrected. Okay. So I think a great case study of this is to really dive into ACL injuries. Okay. So if you look at ACL injuries in the youth population, the number of ACL reconstructions are rapidly increasing. Okay. A lot of this is due to sports culture. It's a fact we're picking up on these injuries, and there are tons of surgical techniques. But we've seen a 400% increase in youth ACL tears, and that's a lot of it's reflective of the fact that kids are playing sports at a younger age. They're specializing, their mechanics are all off. And this is particularly the truth in youth soccer. We're seeing a 111% increase in youth soccer injuries over the last 14 years. And this is particularly affecting female athletes. All the data is showing this increasing trend. When I look at my practice, you look at what my average ACL age was in gender. When I first started, it was probably like a 17-year-old male who played football. Now it's a 13-year-old female who plays soccer. That's like 75% of my ACL injuries that I do, okay? So you've definitely seen a trend that's going down. Now, a lot of people will talk about, well, what are the increased risk of ACL injuries in females? Is it due to anatomy? It's due to all these other things. Where I think it's from is the fact that there's a lack of strength and conditioning work and biomechanical work that starts at a young age, right? So you see the 8, 9, 10-year-old boys that are playing soccer, they're doing FIFA 11, they're doing this other stuff, they're doing core work, et cetera. That doesn't start much later for female athletes. So as a result, we're seeing these injuries increase a lot more in this age group. So as a result, one of the things we need to do is change the paradigm in which we're looking at these injuries and looking at it more of a dynamic injury as opposed to just a static process. You have your ACL, it's healed, and you go back, okay? And you can see these numbers particularly, and these are primarily sports where there's a vast majority of females playing. Now, the important thing is not just necessarily the fact that you have an ACL injury, right? We know how to fix it. We know the rehab protocols. We can get people back. But the reason why things like motion analysis are really important in the pediatric population is the failure rate for surgeries in this population are significantly higher than the adult population, right? So in the adult population, you get your ACL done, the failure rate's about 2 to 3%. You go on, you maybe ski once a year, play a little recreational basketball, not a big deal. But for this pediatric population, they're stressing their reconstruction so much more. So what can we do to optimize or decrease that injury risk? And a lot of these injuries where they re-tear are not the contact injuries. It's not that you had your ACL done, you go out and play football, someone runs into your leg. There's nothing you can do about that. It's the non-contact injuries we need to worry about, right? So you can have your strength optimized, you can meet all your criteria, but how you're moving and how you're jumping, how you're running isn't optimized. And that's the reason why we need to decrease that and decrease this failure rate. So you look at some studies that have looked at ACL reconstruction in pediatric patients. This was a study that was done out of in San Diego, and their failure rate was 10%. It's about 8% higher than the adult rate. This was a study that was done out at Duke, and their failure rate was actually 20% after ACL reconstructions. Okay, you would never tell an ACL patient, an adult, you say, hey, you're going to get the surgery done, and your 20% chance you're going to fail again. Okay. This was a study done out of CHOP, and they once again had a 10% failure rate as well too. And this was a study at Mayo Clinic that they looked at 17 years of ACL reconstruction. They found that there was a 28% of repeat surgery, all right? So once again, we're emphasizing this isn't just like you get your surgery done, you go back and play. There's something we need to be doing to improve the outcomes for these kids after surgery. And it's not because these surgical techniques are any different. The ACL is going in the same spot as it does in an adult. Maybe we kind of avoid growth plates, et cetera, but it's the same surgery that adults are getting, but they have a much higher failure rate. So we need to look at, well, what's the modifiable risk factor? And for the vast majority of these kids, it's how they're moving dynamically, okay? And what group is particularly the most susceptible, okay? So this is a study that was done out of New York at Hospital for Special Surgery, and they kind of looked at their ACL patients who are pediatric patients. So like the ones who are under 10, kind of the middle school ones, and the ones who are in high school. And basically that middle school group had the highest re-injury rate, right? Now, that's not necessarily surprising, right? So we talked about that this is the age group that's going through puberty, right? So they're going back to sports. they're going back into competitive sports. They have all these neuromuscular changes going on, and they're trying to get that college scholarship. So of course, they've got all these factors coming together, and they have a 20% failure rate. If you're 9, 10, or 11 and you tear your ACL, most of the time your parents are going to be like, look, you're not doing cutting or pivoting sports, you're 9, you change it. And if you're 16, 17, or 18, that older group, you're probably making the decision at that point not to go on and play competitive sports. So that 14-year-old age group, which is rushing back to sports, is going through all these changes, clearly has risk factors for this. So what's the role of motion analysis in optimizing their ability to return to sport? And we'll talk about that. Okay. So when you think about this higher failure rate, it's not really graft choice. It's not necessarily the sport that they're playing. Most of these kids are compliant with PT. It's not necessarily the surgical technique, and it's not really skeletal development. A lot of it has to do with their mechanics. Okay. And when we talk about the higher failure rate of pediatric patients versus adult patients, if you kind of look at this bar graph, there's a study where we basically looked at adult patients who had ACL reconstruction kind of systematically, pediatric patients, which is the red bar, and then looked at professional athletes, okay? So you can see pediatric patients are much closer to the re-injury rate in professional athletes as they are compared to the general adult population, okay? So clearly there's something going on there because a lot of the 12, 13, 14-year-olds aren't exerting themselves like a professional athlete does, but they're tearing their ACLs at the same rate or close to the same rate that those professional athletes do. So there's something we need to do to decrease that down. And the reason why I want to decrease that re-injury rate is because you don't want a second ACL surgery when you are an adolescent patient, okay? So if you look at the outcomes of revision ACL surgery, these patients have a high re-tear rate. They have really poor patient-reported outcomes. We don't want an 18-year-old to have 2 surgeries by the time they're heading off to college. Their knee's going to be arthritic. They're going to have difficulties. So it's not just about getting them back to sports. It's making sure that they're healthy for their entire life. And it's really looking at the factors that can prevent that. And this isn't just ACL surgery, okay? The reason why we need to look at motion and how people are doing after surgery is that in general, surgical reconstructions in this population do poorly. Patellar instability surgery, there's about a 25% chance you'll dislocate your patella after surgery. Shoulder surgery, 17 to 51% based on one study you look at. Meniscus surgery, 20 to 25% failure rates, okay? So a lot of this has to do with the fact that we need to change. We can't just accept this failure rate. A meniscus is fixed the same way. You fix a labrum the same way. But are we really looking at how they're moving and how they're doing activity because they're stressing themselves the appropriate way, okay? So one of the things we deal with when you have such a high population, you've got this family in your clinic and they ask you, well, what went wrong, okay? Why is this occurring to my child? We're supposed to get back to playing sports. They got cleared, everything's great. What can we do to help prevent this, okay? But I think the important thing before we start talking about mechanics is also understand that for these kids, it's a very traumatic event that has social and emotional implications for them. Many of you have children who take care of a lot of young athletes, like social life revolves around sports, right? Mental health revolves around sports. So if this kid comes in and then suddenly they tear their ACL and they're out of their club season for the full year, their parents don't have friends because, only parents have friends when they play club sports, right? So they don't know what to do on the weekend, okay? The kids, all their friends, they play on the club team because no one hangs out at school anymore, right? Because they all just go play their sports on the weekend. And then they can't physically work out, right? Even at a basic level, physical activity just makes kids feel good, okay? So how can we prevent this from happening, okay? And I think that's really the key. It's about how do you prevent it to optimize outcomes, okay? So I think it's not just like doing the same surgery again, right? Okay, you're just going to have the same thing happen again. So what can we do to decrease that? Okay, so in this culture of the crazy cone yelling coach, puberty, money, anatomy, it's about dynamic, right? It's about movement. We do all these surgeries because we want people to get back and be dynamic, right? These surgeries are static, but movement is dynamic. Okay, so how do we make sure the dynamic component of return to play is optimized, right? In our clinic, we know about how long you've been through surgery. We check your mobility, we check your strength, we test your graft. But we're not having someone go out and run and cut and pivot in clinic over the course of an hour to see how they do. But that's really what they're doing. That's how they're stressing themselves. It's like buying a car and basically looking at the car in the lot, not even going in the car and saying, yeah, I want to buy that one, right? Okay. You need to know how it drives. You need to know how it handles in multiple situations. But we're doing these crazy surgeries and we're not utilizing that to see how athletes are ready to or preventing their risk of injury. So that's the way I need to think of it. So, how many of you know Robert Griffin III? Not the social media Robert Griffin III, who's kind of crazy, but this one, okay? So he played football and ran track at Baylor. Phenomenal athlete, right? One of the last kind of true successful multi-sport athletes at the collegiate level, okay? Great athlete, got drafted in the NFL, okay? Look at his NFL combine, okay? This was at the NFL combine. What do you notice there? What's he doing? I heard someone say valgus, right? Yeah, exactly, okay? So tremendous athlete, achieved at every single level, NFL combine. They look at his kind of his vertical jump. You see how he's landing. What was his NFL career characterized by? Multiple knee injuries, right? Multiple non-contact knee injuries, okay? So once again, when we look at this, we're like, oh, you're doing great. You're playing at Baylor and you're running track, right? It's great. But then no one ever looked at his mechanics, right? And as a result, what happened to his career, he got all these non-contact injuries, okay? So I think that's where we need to kind of shift it over to our youth athletes, okay? Because if we're just doing the regular return to play dogma, and I'm using ACL, you get your brace and crutches, you start running, you do agility, 9 months, you go back to sport, okay? But we really need to be looking at this, okay? Because this is what's going to determine, for the most part, whether someone re-injures themselves or if their performance is even going to be good, right? Because even if you don't re-injure yourself, if you're running around dropping into valgus, your knee's going to hurt and you're probably not going to be biomechanically efficient, okay? So the way that I like to tell parents and these kids is that we're doing these advanced things to look at your mobility because, number one, we want you to not get re-injured, but also you'll be a better athlete if these things aren't happening, okay? So you get the buy-in, you get all this data for them, and I think that's really, really important, okay? And the other reason this is important is even though we clear people at 9 to 12 months, if you actually look at when biomechanical asymmetries get better, it's usually about 24 months, okay? So when you look at professional athletes, I think that's some of the best data. If you look at NFL players, NBA players, et cetera, their statistics return year 2 and year 3, okay? And part of that's because they're getting their shape back, but part of it just takes a while to get back to moving normally and to basically make sure your mobility is better. So if we understand that there's still these asymmetries at year 2, we need to identify them, right? We don't just clear them from our clinic or clear them just because they've passed some two-dimensional tests. We should be looking at it more thoroughly to make sure that they truly are ready and also make sure that there are exercises or other things they can do in that gap between getting cleared and returning to play so that they can optimize their performance and decrease injury risk, okay? So as I like to tell patients, structure is static, but movement is dynamic, okay? So we've done great with the static part. We're not doing very good with the dynamic part, okay? So we really need to understand how each athlete is moving. And even when you look at the AAOS, our orthopedic surgeons kind of return to play consensus statement, there are all these things, like mobility, strength, make sure they don't have pain. And we just says, oh yeah, make sure they have restoration sport-specific skills. What does that mean, right? Like, hey, can you play basketball? Yeah, sure, I can go play basketball, right? But there's not actual criteria for how we're restoring them. And this is where things like looking at mobility and motion after an athlete's been cleared is really, really important, okay? So if I kind of use this, kind of as example, the conditions that we have, whether it's arthritis, whether it's knee pain, they impede your biomechanics. That's the reason why we're concerned about it, right? Yeah, like in our population, kids will have pain, but they really just want to be able to move and do things, right? So, we do these diagnoses, we do these treatments, we do all these things to get people back to their function, but then we don't test how their function actually is, okay? So I think that's really important. And it's hard to assess in the clinical setting, okay? Even if you have 30 minutes with a patient, you just can't get someone to basically recreate how they're moving out in the field. And, we check motion, we check strength. There are little things we can do like, walk and all this other stuff. But once again, they're not recreating what they do in the clinic, out in the field, excuse me. So why is motion analysis important? Well, motion analysis is something that uses all this technology to look at movement dynamically, not just mobility, but also muscle activity, forces, all these various things. And this is where if we have the data, can do it in a very equitable way that's cost effective, we can really make a difference, okay? So the way I like to think of it is obtaining information about dynamic movement to avoid injury and improve performance. That's what it is, okay? It's really about getting that dynamic component. And that can be done in various different ways, okay? There's iPhone technology, you can do it, okay? You can get apps that look at your motion and can identify very kind of large risk factors very quickly. The Microsoft Connect is that's the second thing there on the slide. It's a very cheap way to look at motion as well too. And then you've got motion labs like we have here or in other places that can really, really help quantify the data. So motion analysis doesn't have to be this, you're putting markers on and you're spending 3 hours in the lab. If you have access to it, that's great. It can be iPhone-based stuff. It can be looking at motion, looking at a video of you running and cutting in slow motion on your phone. So there's each level of motion analysis, but even the very basic one is really, really important. So the problem is that there's not much data in the pediatric and adolescent population, okay? There's tons of adult data, okay? So pediatric data is limited, and that's where some of the cost effectiveness becomes a little bit more difficult because insurance doesn't want to pay with it. You have to get creative in terms of using Motion Lab for return to sports performance because for a lot of insurance companies, they just want you to be able to walk and say you're going back to sports. They're not necessarily concerned about sports performance. And even when you talk to insurance companies, you say, well, we're doing this so they don't re-injure themselves because the cost of a re-injury and a resurgery is really high, they kind of don't listen to it, okay? So there needs to be more data, and there's great opportunities for anyone who's interested in research to kind of look at the impact of motion analysis on the pediatric and adolescent population, okay? So if you really look at the studies there's really a lack of studies on three-dimensional analysis. Most of them, which I'll go over, talk about when you have an injury, what are your mechanics, not necessarily how does motion analysis prevent injury. And really the future research, which kind of some things we're doing here, should be identifying those risk factors and looking at motion analysis in terms of developing new rehab protocols or return to sport, as opposed to just saying, hey, this is what happens when you're injured, okay? So motion analysis is important because it assesses injury risk. You can develop specific injury prevention protocols that's specific for the athlete, okay? Not just for all athletes, but for the individual athlete. You can develop post-injury rehab protocols and assess readiness of return to play, okay? So here's an example of patellar instability. Two-dimensionally, if you watch a YouTube video, the knee is flexed and valgus, and the quadriceps contracts, and the kneecap pops out, right? But when you look at it more three-dimensionally, okay, what's happening is you're seeing all these angles. It's not just a knee issue, it's how your leg's landing. You're landing in valgus, what your angles at the hip, et cetera. So then you get a better sense of, okay, if you've got patellar instability and these are the mechanisms that cause it, how do we develop a rehab program that basically counteracts that? And when you may subsequently be ready to go back, are some of these factors still there, okay? So that's kind of the paradigm you have to look at it. When you look at something like a discoid meniscus, same sort of thing. These kids walk in, they have a stiffening strategy, they have decreased peak knee flexion. So these are things that you can pick up and say, okay, well, I'm going to do a surgical intervention on them. Okay, let's get them into motion analysis. Hey, some of these things are still there. Do we need to work on it? Or maybe I didn't resect enough meniscus. So it kind of helps change what you're looking at. Same thing for PCL injuries. You'll see a quadriceps avoidance gait pattern. So once again, how do you assess, when someone is treated non-operatively? Have they avoided some of those gait patterns because you could see in motion analysis, or did you do a reconstruction on them and some of those things are still there? So it's not just, it's going from a timeline-based program or a kind of a strength-based programming to more of a dynamic-based program. And patellar tendonitis, which you see a lot of, one of the things that patients with patellar tendonitis will do, they're more likely to squat with a pattern of increased knee valgus throughout the squatting motion. So if you see this, you could do this in the clinic, but sometimes it's hard, they're not warmed up, et cetera. But if you do this using your iPhone or even in the physical therapy setting, you see these patterns that we want to counteract. So it's not just necessarily about getting rid of the discomfort, it's about changing the mechanics that led you to have that problem in the first place, okay? And although also kind of other mechanical patterns with patellar tendonitis. And then anterior knee pain, which we all see, which is the bane of anyone who takes care of pediatric and adolescent athletes, okay? A lot of these kids will have valgus when they're doing their squats, okay? And the reason why I bring this up and I show these kind of pictures again and again to parents is that they come in and these kids are all like great athletes, right? They're like playing tons of sports, they do 20 hours a week of sports, but then you get them to do a single leg squat, or you get them to do a double leg squat and they all drop into valgus, right? And then that light bulb goes off. It's like, hey, why am I in physical therapy? Why are they working on my core strength? Why are they working on my landing? Well, it's not because your quads aren't strong enough, it's how you're moving dynamically, okay? So all these things are kind of factors that we work on. Where I think there's been tons of data, the one area of pediatrics where there's been tons of data is the ACL, okay? How many of you know about ACL prevention programs? Probably the vast majority, right, okay? So that's where I think kind of spurred a lot of the mechanical kind of data, because we are seeing such a high re-injury rate, and say like, okay, let's prevent kids from getting that ACL injury risk to begin with. So you've got the PEP program, you've got the FIFA 11, you've got sports metrics, and basically what all these programs are doing are trying to improve the mechanics of the individual dynamically so you're less likely to have a non-contact ACL injury, okay? So we have all these ACL prevention programs that have been around for 15, 20 years, but we haven't kind of then transitioned that over into, why don't we just look at this, because mechanics are important, why don't we look at it at people after injury, or basically then look at this at other injuries as well too. So I think it's important when we talk about these programs that we emphasize these things, because it's helping to treat some of the dynamic issues that are there. And the studies on injury prevention for ACLs are actually pretty remarkable. I mean, this study showed, it was a systematic review, found that non-contact ACL injuries can be decreased by 64%. Some studies have shown 75% as well too. So the fact that, you'd have any medical intervention that could decrease anything by 65 to 70%, we'd all be doing it, right? Like if I could say, here's a pill that'll decrease your heart attack risk by 75%. Everyone would be doing it, right? But for some reason, even though we've had this great data about mechanics and ACL injuries, we still lag behind of doing this type of intervention when we see kids for other types of injuries as well too. And then once again, another study that's looked at that. And when you look specifically where some of the biggest power has been particularly in female athletes, and it's even in short bursts of doing this training, right? So we talk about motion analysis, and I talk to this with parents, and a lot of them are like, that's great, my kid has run and jumped the way that they have for the past 15 years of their life, right? So how can you, in a period of a couple weeks, change it? It's like overwhelming. But when you look at these ACL prevention programs, they've shown to change dynamics in as little as 8 to 12 weeks, okay? So this isn't in some sort of big commitment you need to make for the next 2 years to change how you run and jump. These changes can be made very, very quickly and very efficaciously. So that's where I think that if you identify deficits in terms of motion very early on, you can do it, you can make a change, okay? And I'll kind of switch up over here to some of the tasks that you can do. So there are various tasks that you can basically look at in terms of motion based on the sport that you do, but you can do running and cutting tasks, you can do vertical jump, you can do drop landing, and then you can get really fancy and do sport-specific mechanical testing. So you can look at, hey, someone's a basketball player, how are they shooting? You can look at how they're kicking, okay? And then one of the best examples, have many of you heard of P3 down in Santa Barbara? Have anyone heard of that group? Some people have, yeah. So look at just go to their website, one time. So a lot of Marcus Elliott's the founder, and he was kind of one of the big individuals who really kind of championed, we need to look at how individuals are moving and cutting. And a lot of, future NBA players or even youth athletes are going down there. They go down there, get this crazy assessment, but he looks at the mechanics of everything, right? He's looking at strength, looking at mechanics, and he's created this database of NBA players, okay? And basically then these athletes come in and you can compare your mechanics, how you do in all these motion tests, NBA players, what their injury risk is, et cetera. So that's really, obviously, this costs a lot, but when you look at globally how we're preparing athletes, these are healthy athletes who are coming in and basically like, how can I decrease my injury risk? Or I am injured, what athlete in this large database do I basically mirror, and what are the things that we can work on, okay? So that's really the next level, right? So we get this huge database of understanding mechanical factors. How do we then change them? What does it mean for individuals long-term, and how can we optimize performance as well, too? And you can also do this as well for upper extremities injuries as well, too. So we get a lot of baseball pitchers who come in who've got elbow and shoulder pain. And besides the fact they're probably throwing too much, a lot of it has to do with their lower extremity mechanics, okay? So this isn't just about you tore your ACL, you're a soccer player. It could also be looking at lower extremity mobility and three-dimensional analysis in terms of upper extremity athletes as well, too. So there's so much that goes on in the core and the lower extremities that really is important for youth athletes, and motion analysis is what basically captures that, okay? So the question really becomes, is this costly, right? So this is great. We've got motion labs, UCSF, we've got one, but how much does it cost? Well, the way I like to think of it is that a revision ACL surgery is $20,000 to $50,000. Okay, that's a huge cost for the healthcare system, okay? So if we can decrease that, that is huge. If you get, a 25% failure rate for ACLs, think of how much money that is, and then how much physical therapy is afterwards, and how much time lost for sport and time lost for work for families. When you start adding these things up, it's a huge cost to the healthcare system. And then if we look at who actually is re-tearing, if you kind of stratify based on race and language, socioeconomic status, individuals who come for those groups are more prone to have re-injuries, right? So that's the group that needs to make sure that we're getting them access to things like motion analysis and biomechanical analysis so we can decrease the burden that they have. Because for a kid whose sports may be the one outlet they have, maybe the way they can potentially get to college, but they're suddenly having a 30% re-tear rate because they don't have access to the same things, motion analysis can help to bridge that gap if it's done in a cost-effective way. Now, obviously here, at UCSF, where we take care of all patients, we can do that cost-effectively. And it's kind of just a video of our motion lab. I don't know if anyone's seen it, but it's kind of over there. You can do it here. We can do it in a cost-effective manner, but you don't necessarily need fancy technology to do it. Okay? As I talked about, the Microsoft Kinect system, which is very, very cheap. There have been multiple studies that have looked at the Microsoft Kinect system and saying, hey, is this something that can be used to look at motion and analysis in individuals? And it's been shown that it's no different than the fancy motion lab. Now, the fancy motion lab can get lots of more data. It looks cool. It's like you can do more stuff. But you get a Microsoft Kinect, you can do that, and you get really good data in terms of injury prevention. And this has been shown in multiple studies. And finally, even just your iPhone, okay? We have some researchers at UCSF who are looking at kind of iPhone-based motion analysis that's very cheap. And even little things like walking, mobility, you can get two-dimensional, three-dimensional analysis that can help to quantify injury risk right at the point of care, okay? So that's really, really important as well, too. And when you look at it from a grand scale, when you're looking at high schools, you're looking at middle schools as well, too. Just think about the math. You can do big screenings, right? You've got an iPhone-based program, Microsoft Kinect-based program. You have all your athletes come through in the fall season. Just have them do various tasks, have them do some motor tasks, have them do a drop jump, have them do a vertical jump, and you can identify those kids who may have some deficits. They're dropping into valgus. Like even choose one thing and say, hey, why don't you do these exercises so then you don't tear your ACL 3 months down the road, right? Okay. Or if you got a bunch of kids who, tore their ACL and then are in surgery, let's just do something simple as that. So it's not necessarily at an academic center. It could be a community physical therapy center. It could be in the athletic training setting as well too. So there's so many ways that we can look at athletes and how they're moving to help improve their performance, as opposed to having them get injured again. So just in the interest of time, in general, I think the way we're looking at youth sports is that we're seeing kids who are getting more injured. There's a higher rate of re-injury in that group, but we keep kind of just hitting our head and saying, this is occurring, we need to change culture, we need to change the way the kids are playing sports. That's really important. But what we can do right now is change the way the kids are returning to sport and that gap between I'm injured and I'm returning to play. And we can do that through the utilization of motion analysis because movement's dynamic, right? Our surgeries are static, but movement is dynamic. And if we really look at individualizing that to each athlete, and then we can work with our physical therapists, our athletic trainers, et cetera, to change their movement patterns, we can optimize performance and prevent them from getting re-injured in the future. All right. Well, I'll open it up to questions. Thanks for having me. I really appreciate it. Does have to be a question about motion analysis. I'll answer any questions. Go ahead, Michael.
Has there been any research? Has there been any research that shows a correlation between re-rupture rates for ACL reconstruction and having athletic trainers at the school? Because it seems like you're talking about there's a gap between, they're not doing those cutting maneuvers in the clinic, and it's even hard in a PT setting.
Yeah.
The one different thing would be an athletic trainer at a school, but there's just a severe lack of them in high school settings. Has there been anyone that's looked at that?
There's been some kind of more case-based series that looked at, and they found that, and that's a great point, is the need to have athletic trainers at every single high school and every single middle school, that would be, as well too, is that that has definitely decreased re-injury rates for all cause injuries, as well as for things like concussions as well too. So I think I absolutely agree that even having another set of eyes that are able to watch that athlete longitudinally and look at their mechanics has been tremendous in terms of decreasing that re-injury rate. The problem is that those studies haven't been larger based, so when you present them to high school organizations or the state said, hey, this is something that needs to be done, and they're like, oh, it's just one high school where that was shown. But I think, even in my own experience as well too, it's been tremendous in terms of decreasing that risk because, so the athletic trainers are able to see that mechanical deficit day in and day out on the field as well.
I just had a quick question about adaptive athletes and children.
Yeah.
Do we see is there research that shows that there's a higher risk of re-tear, re-injuries, or is it lower because a lot of times they have that extensive physical therapy?
Yeah, that's a great question. So it's interesting. So a lot of the early motion analysis was done on adaptive athletes because a lot of them are getting motion analysis done for their neuromuscular conditions, et cetera. So actually their re-injury rate is much lower because that group is really being looked at dynamically, right from the get-go. And the braces that they have, the therapy they've gotten, so that re-injury rate is lower. So I think that does speak to how we need to kind of then transition that over to the non-adaptive athlete as well too. That's a great point, yeah.
I have a question. As a mother of a female athlete, high school female athletes, basketball players, and a pediatric nurse practitioner in primary care. So when I'm picturing my daughters would not listen to a word I said if I talked about ACL prevention. So what age should we talk about it in primary care and I'm just picturing in PE class or help the coaches make sure they're starting this in their practice? Yeah,
no, that's great. I think we should be starting in elementary school. I think we should start it really, really young because I think that then you get that becomes normal, a part of it. You brought a great point about PE class. We all have, we all have different memories of PE class, okay? But if you actually look back at what you learned in PE class, a lot of it was ACL prevention stuff every single day, right? You climbed a rope, you learned about flexibility, you learned core stuff. You had that old 50-year-old guy yelling at you, but you started in elementary school, right? And I think a lot of this, only 29% of high schools have daily PE, right? And even elementary, middle school is even lower. So I think a lot of the things that we learned in PE in terms of injury prevention and doing those things is lost, and that correlates with that injury risk as well too. So I think if we started elementary school, particularly for female athletes, I think it gets that mindset of like, okay, this is something we need to do. It's not just about developing skill, it's about starting to work on, mechanics and conditioning and strength as well too. So starting it young, because I think once they get 11, 12, 13, then the ship's already sailed. It's gonna be hard to do that, yeah.
In light of good resource utilization and stewardship, at what point are you introducing the gait analysis into your treatment plan? Are these chronic pain kids? Are these post-op kids? When do you use it?
Yeah, so I think, at least in my practice, I think it ends up being a combination of all those. I think the post-op patients, it's pretty algorithmic. You get to your ACL time. We get a handful of kids where, they're looking to prevent injury, and we'll do like running analyses on them. So that's a little bit more of them asking for it, I think, in the context of the clinic. But I do think that where I've started to use it a lot more are the chronic pain kind of patients, because a lot of them have kind of jumped from place to place to place. They've done PT, they've done all those other things, but no one's ever looked at their movement, like how they're doing things. And a lot of times that is what actually kind of breaks that cycle as well, too. So I agree. I think a lot of it is, I think where the difficulty becomes is then, connecting that patient for them to have the time to do it as well too. But I do agree that more and more I'm starting to do that in clinic, and even using iPhone-based stuff in clinic as well too. Yeah.
Yeah. So where I work up in Sacramento, we're lucky enough that we have a biomechanics lab, which produces these wonderful reports with all this data.
Yeah.
I was wondering if you had any pearls of wisdom about what to do with all that data. I'm thinking about, we had one D1 quarterback who, you look at the data and it's like, oh my God, he's got this terrible hip strategy. Like, we can't clear him. You look at the video of him doing the drop jump, and he's literally like jumping almost through the ceiling tiles, like so far above the normal curve. And it's like, so do we like tell him he can't go back to playing sports when he's jumping through the roof? Yeah. So what do you do with that?
Yeah, no, that's a great point. And I think that's where we got all this data. What do we do with it? So I think the kind of two little points about that. One is, with a lot of these athletes, and we know this very well, they're very perfectionist, okay? So the number one thing I always tell people is that they'll get caught up in like the numbers, right? So I tell kids, you didn't fail your motion test, okay? You didn't fail this. This is data, and this data we're going to use to create strategies to help decrease injury risk. So I think that's the number one thing. It's like no one ever fails it. And I tell a lot of these athletes, like a lot of these deficits are probably here, as we talked about, for years, right? And now we're just capturing it. So I tell them we're creating a general strategy to prevent re-injury risk. And then, as Michael mentioned, like the athletic trainers are really important because they're seeing them, like move and do all things appropriately. So I think you're getting data from outside places. And with all the data, I really like to say, let's pick one or two things that are really important, right? And say, like, this is something that you can work on in combination with how you're looking mechanically. So I think it is another huge amount of data over there, but looking at one or two different things. And then I think as we get more research in our population for this, because that's where I think we struggle, is like, okay, we're looking at pediatric and adolescent athletes. Let's do this large scale. What are the actual important things that we can use for performance, right? Because I think we know what will increase risk, but like, are you ready to perform at your optimal level? And I think there's still so much variability in young athletes at that age. Yeah. Great. Thank you, everyone. Appreciate it. Yeah.